to all of us in our minds. So I'll be addressing these 8 questions. How is adult different from pediatric ALL? How can we risk stratify our patients of adult ALL? What chemotherapy modifications are typically done? The role of MRD, then special subsets like early T precursor and the PH like ALL, the role of hematopoietic stem cell transplantation in CR1 in adults, and of course, for the relapse refractory setting, where are we with the CAR T cell therapy, the immunotherapies like the BiTEs and the antibody drug conjugates? So now coming to the first question, how is it different from the pediatric ALL? Now this is a slide of pediatric ALL, and as I just mentioned in my introductory slide, the various graphs are over a period of decades as highlighted on the legend on the right side. If we see in the 60s, the pediatric ALL, the long-term survival, 10-year survival was just around less than 20%. In fact, it was just about 10% or even less than 10%. Same as in the 70s. But as we started, I'll just get a laser pointer. Yeah, now it's easier. But just see how as the decades progressed, how the outcomes of pediatric ALL changed till in the series, and a large series of 3,400 patients between the 90s to the year 2000. If we see up to a 4-year or a 5-year, the survivals were close to 85 to 90%. This is the story of pediatric ALLs beyond 90s, that is of this century. And if we see the BFM group, the Children's Oncology group, and St. Jude's, all of them have reported long-term 5-year EFS in the range of 80s to 90%. So this is the success story as far as the pediatric ALL is concerned. Now this is data which was a meta-analysis which was for Indian pediatric ALL series published after the year 2000. So this is reasonably recent and contemporary. So most of us, so we've got studies from TMH, AIMS, CMC Vellore, PGI Chandigarh, AIMS, Sir Gangaram Hospital and RGCI. If we'll see, our results are not comparable to what has been published in the West, but still we are reasonably quite close there, 67%, 58%, 60%, 67 to 70% in various pediatric groups reported by our Indian publishers, and just contrast it with what happens to the adult ALL. Now this is a series of adult ALL. Please take note of the age at which these studies have been conducted. More than 60 years, 55 to 60 years, 51 to 75 years, and please concentrate on this column of the overall survivals. 3 years survival, and mind you, these are all multicentric, prospective, and some retrospective trials from the Western world. 3 years survival of 43%, and if the age was more than 60 years, it will plummet down to 17% survival. Similarly, the ECOG, 5-year survival, 21%. The GMOL, 5-year survival, 23%. And these are very respected multicentric groups. So this is the story of adult ALL in the Western world. Just as a comparator, this is a nice study from Indian, the largest, CMC Vellore. My friend Dr. Puneet Jain has put across this data of 507 adult ALL patients from CMC Vellore. And when they split their patients into the standard risk and the high risk group, even the standard risk group means everything good about it. And mind you, this is a highly selected patient population who were good affording patients who went ahead and took treatment. Even in them, the best outcomes is around 60%. And in the high risk group, depending on what chemotherapies they gave, whether the GMOL or hyper CVAD, the survivals, long-term survivals in 5 years are just in the 20s and the 40%. So definitely we know that adult ALL is not at all a good story. So how can we risk stratify our patients of adult ALL? So essentially, risk stratification aims at modifying treatment intensity to specific groups of patients so that we can offer personalized and what today is the buzzword, precision therapy based on the specific risk group. There are tools which have been used for stratifying our patients. Historical have been morphology based, like the FAB classification, the clinical characteristic based, in which we classify our ALL patients into the various groups like the standard, intermediate, and the high risk. Cytogenetic based classifications. The most recent one and the most reliable one is the MRD based classification. And of course, still an experimental, not yet in clinical practice, is risk stratification based on gene expression profiling. Now, the earliest wave in which, in the way back, Dana, they try to classify ALL was the L1, L2, and the L3 based purely on the morphology and the cytochemistry. Dr. Barbara Baines was the first author in which they classified this ALL into three and tried to distinguish some outcome differences, whether the person or the patient had an ALL L1 or an L2. Then, of course, a much more robust classification came based on clinical characteristics. So we had patients, what is the adolescent and young, that is 15 to 39, 40 to 65, and more than 65. And this is because they were in this age group, that is the 15 to 39, that is the AYA group. They could be treated with pediatric based chemotherapies, and hence the survivals and outcomes were much better. TLC at diagnosis for B cell more than 30,000 or less than 30,000, and for a T cell ALL more than 1 lakh or less than a lakh, distinguish them between the two groups. Whether there was an involvement of extramedullary site, and what was the early steroid response, especially at day 8 prednisolone response, whether the absolute blast count was more than 1,000 or less than 1,000, that categorized the ALLs into two groups, and based on which we classified our patients as to high risk or standard risk. Now, more important was the genetic classification. So now this busy looking slide is actually put together all the cytogenetic abnormalities that we have known, whether it was karyotyping based high hyperdiploidy, the near haploid or the low hypodiploid cells. And it's a combined slide in which it gives a frequency both in children and adults on the right side. So like this is extremely rare, high hyperdiploidy in adults, whereas the low hypodiploid is pretty much more common in adults and very, very less in children. And that gives rise to the prognosis. So we'll see extremely poor prognosis with the low hypodiploid, and other cytogenetics balanced translocation like the translocation 1221, 30% in adults, but very less commonly seen in adults. And similarly, when we come to the BCR ABL, we'll see it is much more frequent in adults as compared to children. And each of these cytogenetic abnormalities have an bearing on the prognosis of the patient, making it either a poor or a very poor or a favorable risk group. Coming to specifically to T cell lineage, now this is a combined not only of pediatric or adult, it's a combined. Within the T cell lineage, the cytogenetic abnormalities are much different from what we saw in the B cell ALLs. And please concentrate on the very last one, the early T precursor. It's around 10 to 15%, which has got a poor prognosis, and we'll be having a couple of slides specifically dealing with the ETP ALL separately. Now, just having known a cytogenetic subtypes is not good enough, because as we'll see, the cytogenetic subtypes and their proportion changes as to which age group we are looking at. So if you see the legend and the colors which they have used to identify the pH, the pH-like, the hypodiploids and the other cytogenetic abnormalities, their proportions varies whether the patient is a childhood, adolescent or a young adult. Now, these are certain key genetic alterations in patients of ALL who otherwise do not have a morphologically identified cytogenetic abnormality on a karyotype or a fish. So we can have genetic alteration in the PAX5 gene, the Icorus zinc finger 1 gene, the JAK and the CRLF2 gene. And similarly, kinase activating what is known as the pH like ALL in the kinase activating gene, rearrangements in their various genes, which give rise to various genetic abnormalities, which will put a patient into a peer risk group. How these genetic abnormalities work is not just in initiating in the initial leukemogenesis. Because of chemotherapy, there is a selective pressure, and that clone which is susceptible to chemotherapy is eliminated, whereas that particular clone which has harbored these certain abnormal genetic abnormalities, they have a survival advantage, and this gives rise to a relapse of ALN. And that is why it is so important to identify these genetic abnormalities de novo at beginning, so that we can plan our patient's treatment quite early on. Now, WHO has recognized, and in 2016 WHO classification, the B cell ALL has been further classified as ALL with recurrent genetic abnormalities, and these are the various abnormalities which WHO has already flagged as having different outcomes, and all others are B cell lymphoblastic leukemia, lymphoma, not otherwise stratified, not other specified. Whether it's for T cell, they have only highlighted one separate subgroup as ETP ALL. Now, coming to our third question concerning ALL in adults, what are the chemotherapy modifications which we typically do? Now, this is a general schema for managing all ALL patients. We initially have an induction chemotherapy where the aim is to induce remission, morphological remission, as in less than 5% blasts on the bone marrow. And we use a multi-agent chemotherapy using a combination of steroids, pink alkaloids, asparaginase, and anthracycline. Then we go on to consolidate with really high dose chemotherapy, in which we want to knock off the residual cells which are otherwise not morphologically obvious, intensify, and ultimately, once we have achieved a deep remission, we go in for a maintenance, which may be anything between 2 years to 3 years, depending on which protocol we are using. Now, in adults, the typical modifications are related to, firstly, steroids. Because of the numerous short-term and long-term effects, especially the ones highlighted in red, are more pronounced in adults as compared to pediatric age group. So many times, because of the behavioral and psychological disturbances, because of a steroid, the physician treating an adult ALL patient is forced to reduce the doses of steroids. Same, hyperglycemia being much more common in adults. These are the various factors which lead to reduction in dose, and hence the results or the outcomes are not as fantastic as we have seen in the pediatric. The risk of side effects of steroid increases when the patients are given a high dose of steroid, and worsen when dexamethasone is used in place of prednisolone, and hence most of the adult ALL protocols use prednisolone as compared to dexamethasone. When we come to vincristine, there is a much higher incidence of autonomic neuropathy, especially intestinal, the paralytic ileus in adults, and hence it is again a drug which is very early on either replaced by vinblastine, the evidence for which is not really robust. We just use it because of its class effect. But in most of the trials, it is vincristine which has stood the test of time, and whether the vinblastine will give rise to similar outcomes, we don't know. But we are forced to change because whenever we get autonomic neuropathy. The second thing which we have all seen is the dose of vincristine is 1.4 per meter square, but in adults we cap it at 2 milligram. So imagine an adult of 2 meters square. When we give 2 milligram of vincristine, we are actually giving 1 milligram per meter square of vincristine. So there again, we are compromising the dose of vincristine. And in a diabetic patients and renal failure patients, the peripheral neuropathy is already a part of the comorbidity. The vincristine further enhances the peripheral neuropathy of this condition, and hence the vincristine dose gets compromised. Anthracycline, again, because of inherent some underlying cardiac dysfunction, the doses are compromised, and enhanced cytopenia due to lower BM reserves in an adult. Very quickly, we land up compromising the dose of anthracyclines by the third week or the second week of induction in our patients of adult ALL. Now, L-asparaginase is a very interesting drug. Why? Because there are various protocols, especially like hyper-CVAD. They do not use L-asparaginase at all. The toxicity of L-asparaginase in adults like hyperglycemia and hepatotoxicity and thrombosis is much more pronounced than what we see in our pediatric age group. And a second, a very unwritten thing is that most of the adult physicians who, especially not in our country but in the Western, where pediatric ALL is treated by the pediatric hematologist and adult by the adult hematologist or the oncologist, because L-asparaginase is a drug which is used only in pediatric ALL, many of the adult hematologists, because of their poor experience of using L-asparaginase, tend to avoid this drug because they are not confident of managing the side effects which L-asparaginase brings with it. So one, use of pegylated L-asparaginase over the native E. coli asparaginase has reduced the toxicity to quite an extent, but again, in most of the protocols, as opposed to 2,500 units per meter square, the dose of adult protocols, PEG L-asparaginase is used between 1,000 to 2,000 only, and it is always recommended to be used with a pre-medication with hydrocortisone and antihistamine given 1 full hour prior, and it really reduces the side effects. The question to my mind was, if there are certain protocols which have completely omitted L-asparaginase, is there any evidence? So yes, there is clear-cut evidence, and all of these papers are in the last 4 or 5 years in which they have proven that a pediatric inspired, that is to say, when L-asparaginase is used in the management of intensive chemotherapy of acute ALL in adults, the results are much better when asparaginase is not used. This was a paper from the UK ALL14 trial in which they analyzed only the toxicities, and they compared when they were not using PEG L-asparaginase as in the same doses as in the pediatric age group. So the UK ALL14 was the first in the series of adult ALLs where they used the same dose of PEG L-asparaginase as they used in pediatric patients. What they found was that toxicity death during induction was almost 16%. In fact, because it is 16 out of a total figure of 91, so it almost comes to around 18 to 20%, whereas the toxic deaths was just around 6% in their previous studies where they had not used L-asparaginase. So this UKLL actually came up with a contrarian results of an increased mortality when they used L-asparaginase, but when they did a further multivariate analysis, they realized that most of the toxicities were because of the overlapping toxicities with other agents like anthracyclines and TKIs. So when they separated off the two drugs in a staggered manner, the toxicities were much less. So their conclusion was that in a pH positive ALL where we have to use imatinib or other TKIs, asparaginase is not to be used. Whereas for others, we can stagger, like when anthracycline is being used, we can use asparaginase at a later time point. Now coming to the fourth question. Again, MRD has been beautifully studied and we know what it is in monitoring pediatric patients of ALL. What is the evidence of using MRD in our adult ALL patients? Now, MRD is minimal or a measurable residual disease, both used interchangeably. It is the most important prognostic tool during early part of therapy, and it quickly identifies patients. So right on day 33 of starting induction, we can stratify our patients whether is he a candidate for an early HSCT before he actually relapses and then tries to go for an HSCT in CR2. And at the same time, we can identify patients in whom we can de-escalate therapy, especially those adults who are unable to tolerate. So MRD is a really helpful tool. The only thing is requirements for a measurable or a minimal residual disease should be that the whatever tool which we are using should be able to give us a sensitivity of less than 10 raised to -4, that is 0.01 or less. It should be applicable, accurate, reliable, and most importantly, fast and affordable. So this is the general schema of an MRD. This line is what is the detection at the level of cytomorphology under light microscopy at between 10 raised to minus 1 or 10 raised to minus 2. And MRD pushes down our limits of detection to as low as the modern tools 10 raised to minus 5. Although if 10 raised to minus 5 is not available, at least 10 raised to minus 4 is reasonably available in almost most of the centers in our country. So this will help us to identify patients who are going in, especially say this category of patients who would otherwise be morphologically in remission, but MRD positive means eventually they will relapse. The two most important available tools for assessing MRD is the conventional flow cytometry or the PCR based testing, whether based on the immunoglobulin or the T cell receptor genes. Both of them have got reasonable and comparable sensitivity, applicability slightly more for the PCR technique, because in many a times we are unable to find, because the flow cytometry is based on identifying an aberrant population of cell, and although in more than 90% we are able to identify both in B and the T cells and aberrant immunophenotype, sometimes we are not so lucky, and it may be difficult to identify the MRD. Whereas in the PCR base, the applicability is more than 95%. It's only less than 5% where we will not be able to identify a specific signature T cell receptor gene which will identify a malignant versus a normal clone of cell. The advantage, however, why flow cytometry in our country has taken off is it's very fast, it is easily available, data is easy to store, easy to disseminate, and most of our pathologists, the hematopathologists, are very comfortable doing multi-parameter flow cytometry as opposed to a technique which requires high amount of standardization, lot of quality assurance rounds, and equipment with which most of our hematopathologists in our country are not comfortable using with. Of course, the disadvantage is variable sensitivity. We have to be sure who is doing our, that's why we should be aware of which lab we are sending our MRD when we are using flow cytometry, and standardization, whether the lab has been standardized or not. Now, if we look at the data from pediatric, this is from the pediatric BFM group, and this is the Interfent, that is the infants less than 1 year of age, both of them German groups. When they stratified their patients into MRD high risk, low risk, or medium risk, and how they called high risk is any MRD positivity at day 78. Low risk is they did MRD at two time points, day plus 33 and day plus 78. So that is end of induction and end of consolidation. If a patient was low MRD negative at both these time points, these patients, these 55 were known as MRD low risk. You can see the almost all of them having an 8-year survival. So at MRD negative at day 33 and day 78, you can almost say that your patient has been cured. Even at 8 years, almost each of their patients, except for one, they all survived. Whereas if the MRD is high risk, is any MRD positivity at day plus 78, they called it MRD. So the BFM group also identified that if a patient is MRD positive, even in pediatrics, the survival is even below 20%. Anything in between was the medium risk, fell somewhere in between. Same is the result if we see for the infants, MRD low risk, MRD high risk. Beautifully, it stratifies our patient. Again, in pediatric ALL, this is for the B and this is for the T. The idea is to highlight that MRD as a tool, if we use it, it clearly stratifies our patient into the future prognostication. The question is, What is the evidence in adults? Now, in adults, I have got a bouquet of two or three graphs from two or three different studies. The first one, this is an Italian study. So this was a study in which they did not use MRD to take treatment decisions. It was a retrospective study where they were doing MRDs in their patients, and the physicians continued to take treatment decisions based on their other parameters. And then they retrospectively analyzed as to how many of them were MRD negative or positive. And the UKs, where MRD was not studied in many of the 30 of the patients, they could not find data on MRD, so that is unknown. So where retrospectively they said that they were giving their standard of care based on their available risk stratifications on cytogenetics as well as on the cytomorphological risk groups. They realized that if the patient was MRD positive at end of consolidation, the survival was less than 20%, whereas it was almost 80%, mimicking a pediatric kind of survival if the patient was MRD negative. Similar is the result from the German multicentric adult ALL, that is the GMOL trial. Again, they used it molecular failed and molecular CR based on MRD because they used the PCR based molecular technique. So that MRD, again, 5-year survival 74% if the MRD was negative and 35% if MRD was positive. This is a very interesting study. This is the French, the GRAL series, in which they had already taken up the patient for a transplant or no transplant based on their cytomorphological and cytogenetic risk grouping, but they kept on doing MRD at baseline without using MRD for treatment decisions. And when they analyzed their data, all those patients who are MRD negative, if they had incidentally not been taken up for transplant, their survival was the best. Because some of these ALL, some of these MRD negative patients who eventually were taken up for transplant had treatment or other GVHD related mortality, and that is why their survival was lower than those patients. But when it was MRD positive, the transplant made a tremendous difference. So if they were taken up for transplant, the survival was almost close to 60%, whereas if they were kept on only salvage chemotherapy, their outcomes at 5 years was around 20%. So this MRD data was put onto their graphs as a retrospective study. So with this, we can clearly say that now all of us who are practicing or who are treating adult ALL patients should use MRD. So the take-home message is we should use MRD. It's one of the most important prognostic tools. This is just a graph to show the Euroflow base. They recommend 8-color flow cytometry and their criteria of high throughput MRD techniques. Now coming quickly to the fifth question we addressed, that how do we deal with special subsets like early T precursor? Early T precursor ALL are that subset of ALL which has got a high risk because it has they are the early migrants from the thymus, and they have got a lot of commonality with the hematopoietic stem cells. The classical immunophenotype of the leukemic cells is CD1A, 82, 52 DIM positivity, and in addition, they for one or more stem cell or a myeloid antigen positivity. It has been reported in between 11 to 12% of TLLs and between 7 to 8% of adult ALL. They have a distinct molecular profile in which Notch1 mutations at may remember we had seen during the cytogenetic is more than 60 to 80% of TLLs are Notch1 mutated, but they have got a much lower incidence of Notch1 mutation. They have got more frequency of mutations in the FLT3 and DNMT3. So this is a paper from Nitin Jain in which they analyzed their patients of early T precursor. They analyzed their entire group of 119 or 120 TALL patients, And when based on their phenotype, they found when they classified them into early T in the blue or the non-ETP into red, we can see nicely the graph separating. So the early T precursor had a much worse outcome as compared to the whether we see the event-free survival or the overall survival. The early T precursor had a much worse outcome. So the recommendation here is that till such time that we have any specific therapy targeting early T precursor, the moment we identify ETP ALL cells at diagnosis, we should keep a close watch, take them for transplant early on. If they are MRD positive at day 33, and even if they are MRD negative at day 33, keep on doing their frequent MRDs. If they become positive, take them off for early transplants, because as of this point of time, we do not have any targeted therapy. The story is slightly different for PH-like ALL, which is a subgroup of B-cell precursor ALL, in which the BCR-ABL fusion protein is negative, but their gene expression profiling is exactly similar to the BCR-ABL1 positive ALLs. The prevalence is around 12% in children, 21% in adolescents, and almost 20 to 24% above the age of 40 years. Most of these patients with PH-like ALL will have MRD positive at the end of induction, and hence they portend a poor event-free survival. Now, it is a very heterogeneous. The PH-like ALL, depending on whether the PH-like ALL is in childhood, adolescents, adults, or in young adults, these are the various mutations. This is an excellent paper by Ching Hong Pui, and they analyzed more than 800 patients of PH-like ALL over a retrospective database going back all the way almost around 20 years. And they could identify different mutations in this PH-like ALLs, but they varied according to which age group of patients they were dealing with. And these are the certain suggested targets. So for these PH-like ALLs, if depending on what mutations we have, we can go for the TKI inhibitors like dasatinib, JAK2 inhibitors like ruxolitinib, even sorafenib and FLT3 inhibitors have been tried. Coming to the last of the special subsets, that is elderly. Elderly ALL, it has to be with a very comprehensive geriatric assessment, because no two elderly patients are alike. We can have a very fit 70-year-old person and a frail 58-year-old gentleman. So just going by the number is not good enough. We have to see the comorbidities, the life expectancy, the other, more importantly, what are the patient's own perspective towards their own disease, their own life expectancy. And based on this I found was a very good and a simple algorithm. We identify whether they are older fit or older unfit or frail patients, and then optimize a treatment, again based on MRD, targeted therapies, psychological support. Certain key changes in our drug intensive chemotherapies is we don't use asparaginase upfront during induction, we use it during consolidation. Instead of high dose methotrexate, we just do use an intermediate dose methotrexate during consolidation, like 500 per meter square. Consider RIC transplants if they are high risk patients and they are fit patients. So early RIC transplants they'll be able to tolerate. Of course, pH positivity, whether in the older fit or the older unfit, should be used because this is reasonably well tolerated. Coming to the role of transplants in CR1, we'll see that transplants in CR1 is most efficacious as compared to if we wait for a second CR or we take up a patient for HSCT in a relapse. The key here is patient selection. We have to find out which is the patient which is suitable for high risk cytogenetics. So now in the current era of TKI, there's a big question mark whether pH positive patients in an era of dasatinib and imatinib should be taken up. Although even now, even till as late as 2015, most of the guidelines are saying if a matched sibling donor is available, a pH positive adult should be taken up for a transplant in CR1. Although the opinion is divided. MRD, again I'll harp on MRD. MRD positivity at end of induction is the single most important takeaway point for taking up or considering a patient for early transplant. Donor availability, a sibling donor, because haplos and MUDs in an adult, especially 60 plus, the outcomes may not be good. But if a donor is available, that should be kept in mind as one of the criteria. Of course, younger the age, the better it is for transplant. Typical conditioning regimes have been cyclophosphamide, TBI with a 12-gray myeloablative conditioning, but fludarabine replacing cyclophosphamide and a TBI using a lower dose of TBI is much in vogue, and now a completely TBI-free flu triothiotepa-based conditioning is showing results as good as the conventional Cy-TBI transplant. Coming to the last 2 points, where are we in CAR T-cell therapy in adult ALL? Now, on 1st of October 2021, the FDA gave approval for the pexucaptagene autoleucel, that is trade named as Tecartus, for adult ALL, for adult B-cell ALLs. And this was CD10 positive precursor B-cell only they took. And this makes the first ever CAR T-cell therapy. Please remember, all other previous CAR T-cell therapies were approved only in pediatrics. The initial, the KITE studies. This is based on the ZUMA-3 trial, and I was really impressed. This photograph I downloaded from the net. The ZUMA-3 investigators had put up a scanning electron micrograph taken. This is a malignant cell, and how the CAR T cells have surrounded, and they are engaging this cell. So ZUMA-3 was a phase 1-2 study evaluating an autologous anti-19 CAR T-cell therapy in relapsed refractory ALL after a fludarabine cyclophosphamide lymphodepletion. They used 3, because it was a phase 1, so it was a dose-finding study. They used 2 million, 1 million and half a million cells per kg body weight. And out of the 54 enrolled patients, 45 actually got it. All of them were adults, median age of 46, but they had patients all the way up to 77 years in their study. Grade 3 CRS, which is the most important side effect, and neurological events were in 30 to 38%, but they were mainly seen in the 2 into 10 raised to 6 cells, and eventually now the phase 2 study is going on, in which they are saying if they take 1 into 10 raised to 3, that is 1 million cells per kg, the overall complete remission rates is as high as 83%. Whereas in the overall cohort, it was 69%, but when they subdivided only the 1 million category, 83%. And please mind, they're all heavily pretreated relapsed refractory patients, some of them relapsing even after an allogenic transplant. This is just a slide I put together to see what the various ZUMA studies were all about. It started with the large B-cell lymphomas and it goes down all the way to patients with other. So series of most of them are ongoing studies. The newer immunotherapies targeting cell surface like CD20, rituximab and ofatumumab, blinatumomab, which is a bispecific T cell engager, targets the CD19 here and the CD3 on the T cell. Something like what CAR T does, CD19 targets here, and of course it is a pre-engineered T cell. Antibody drug conjugates, the most important being inotuzumab ozogamicin, in which they target CD22 and deliver the cytotoxic drug straight inside the malignant cell, and of course the TKIs. Then for T cell ALL, we've got specific agents like the gamma secretase inhibitors and the daratumumab being still in early studies, not yet published, but showing promising results. So inotuzumab, of course, this itself is a big topic, so I'll not go into details of inotuzumab and the blinatumomab. Suffice it to say, in 72 adults and 326 adults, 2 studies. This is a phase 1-2 study and the Contagion study in the phase 3 study. In heavily pretreated relapsed refractory patients, the overall survival is 30% at 12 months, and this is overall survival pretty impressive when we consider the subset of these patients in whom we are dealing with. Similarly, blinatumomab, Contagion study of 2017 and the top study of 2015 showed that almost they had in the patients of the heavily relapsed refractory patients decent outcomes. Even 24%, 17 and 24% look here less, but we have to remember these are those patients who had been given up for palliative therapy. A comparison between blinatumomab and CAR T cell therapy, comparable. Yes, CAR T is not so. In fact, it is not readily available in our country, whereas blinatumomab is available. My last slide deals with a thought. It's a very good paper by Luskin from the Dana-Farber. Can we think of chemotherapy-free treatment of adult ALL? And that is what they are trying to say in adults, especially above the age of 55. They are going for studies. They are all prospective studies in which they are upfront starting, say, inotuzumab with mini-hyper-CVAD. Or blinatumomab induction, mild intensity, or induce with the inotuzumab and go for a conventional chemotherapy consolidation. Nitin Jain has tried venetoclax and mini-hyper-CVAD. Please look at this response column. 98% overall response rates, 100% CR rates, 91% CR rates with 100% MRD negativity. And which patients are we looking at? Patients who are above 60 years and in this age group. So once these are all early stages of prospective the study, some of them have just about completed 1 year or 3 years. Maybe when these results come up, maybe in the next 2 to 3 years, I believe the next 2 to 3 years are very exciting, because if this is the future, then we may say absolute goodbye to the standard chemotherapy in our patients for adult ALL. And of course, the dose, the cost and the availability will be an issue. But we may be inducing in 5 years from now, inducing our patients with just, say, an inotuzumab or a venetoclax, and then giving some kind of a mild chemotherapy later on. So with this, I come to an end of my presentation. And any question and answers which will, in case time permitting, we are unable to address, this is my email. I'll be happy to share any questions. And even if somebody wants, because I have got a reasonable repertoire of all the material which I had downloaded and collected for making this presentation, if anybody wants any of these copies, please feel free to ask me, and I will mail these original PDF articles to you for your further studies. Thank you so much.
Thank